If there's no objection, that's perfect. Thank you. So welcome everyone. My name is Annie Benzie. I am the chair of the fellowships subcommittee for complex GI fellowships, or SSAT. Today is our Grand Round series. I'd like to introduce our moderator. Dr. Kent Kircher has been gracious enough to go through our topic today, which I think is going to generate a lot of discussion. He is the Chief of Minimal Access Surgery and co-director of Carolina's Hernia Institute, as well as the co-director of the Atrium Health Advanced GI and MIS Fellowship in Charlotte, North Carolina, the place where they created the CEDAR app. So I figured it's best to have the experts at this talk. So if you wouldn't mind, Dr. Kircher, take it away and introduce our talk today.
Absolutely. Thanks for the invitation. This is a very timely topic. I was almost late for the meeting because I stumbled into a laparoscopic repair of a Morgagni hernia this afternoon on a patient that had a questionable diagnosis of cirrhosis, and I got into the abdomen. Fortunately, she did not have a lot of ascites, but she had varices everywhere, and it was an awful case. It went okay, but it was tough. So I'm coming off of a case in which I kind of stumbled onto a cirrhotic, and I would say, and I'm looking forward to the talk, because I think that's kind of unusual, and I think you're going to present a case where maybe you even stumbled into a situation with cirrhosis, and in my experience, it's usually the opposite. I most of the time I know these patients are cirrhotic preoperatively, and I think a really big component of dealing with these patients effectively is preoperative strategies to kind of deal with mitigating risk factors. And I think you're going to talk to us about really what we all struggle with, which is when do we operate electively on these folks with cirrhosis and or ascites and portal hypertension, and which of those do we wait until it's kind of a necessary procedure? And I think you'll probably educate us, Rana, that waiting may not be the right answer for a lot of these folks, because the risk of actually operating emergently on a patient with cirrhosis is quite a bit higher than maybe biting the bullet and taking care of these patients electively. So I look forward to your comments.
Thank you very much, Dr. Kircher, for taking the time to moderate this talk, and thank you everybody else for this opportunity to present here today. Like we talked about, we'll be discussing aspects of hernia repair in cirrhotic patients. So I chose this particular case because I think that, as you'll see, unrecognized liver dysfunction in this patient did lead to increased postoperative morbidity for this patient in what otherwise would have been a fairly elective ventral hernia repair. And kind of just thinking back on experiences in residency, I did reflect back on the complicated hernias that I did see in cirrhotic patients, and although they were rare in occurrence, they were once again associated with significant post-op morbidity. So I thought covering this topic would be very important. So just going over an outline of my talk, we'll go over some background statistics. We'll discuss the case report, and then we'll talk about pre-operative management options in terms of medically optimizing the cirrhotic patient. And then we'll go over some technical considerations with regards to the hernia repair. So chronic liver disease and liver cirrhosis is actually the 12th leading cause of death in the United States. And this is owing to an increased incidence of viral hepatitis, as well as the obesity epidemic, which is associated with non-alcoholic steatohepatitis, or NASH. The incidence of umbilical hernia in cirrhotic patients is about 20%, and this number can go as high as 40% in the setting of ascites. And several factors do contribute to the development of hernias in cirrhotic patients. One of these is malnutrition, leading to muscle wasting and weakening of the abdominal wall musculature and fascia. You have increased intra-abdominal pressure from the ascites itself. And then you can have recannulation or dilation of the umbilical vein, which is going to physically dilate that supraumbilical opening. So moving on to our case discussion, we have VM. He is a 69-year-old gentleman that we initially saw in clinic in consultation to discuss elective incisional hernia repair. In terms of his symptoms, he was having more intermittent pain from the hernia, and he was noticing an enlargement in the hernia over the past couple of months, but he was denying any obstructive symptoms at the time. His past medical history was significant for multiple medical comorbidities, including end-stage renal disease on dialysis, atrial flutter. He had a history of coronary artery disease with a history of coronary stenting, moderate aortic stenosis, as well as pulmonary hypertension. His surgical history was significant for a remote open colectomy performed for diverticular disease. And his medications were notable for anticoagulation and antiplatelet therapy. On exam, he did have a soft reducible hernia along the midline incision. And at the time of the exam, it was felt that his fascial defect was approximately 8 centimeters wide. So he did have a CT scan without contrast performed approximately 6 months prior to the hernia repair. And these are just representative slices from the CAT scan. And here is just demonstrating some moderate to a large amount of ascites. And not shown in this CT scan, he also had evidence of bilateral pleural effusions as well. And he had this CAT scan performed for presentation to the ED for partial small bowel obstruction. But the SBO was thought to be secondary to adhesive disease rather than obstruction, mechanical obstruction from a hernia. So before moving on with the case, I would just like to pose 2 questions to the audience. One is, would you consider this patient for elective hernia repair? And then secondly, what hernia repair approaches would you consider for this patient?
Dr. Guzowski, you want to give us your? Thank you, Jayaraja. Dr. Jayaraja, no OMG.
Yeah, sure. This is Andrew Guzowski. I'm the fellow at Orlando Advent Health Orlando. This is, luckily, he's presenting with a partial small bowel obstruction, so you don't have to do anything emergently or urgently, it sounds like, which is fortunate. And I think I would try to optimize him before electively repairing this thing. Try to minimize his ascites with diuretics and or possible paracenteses. But I think if I did a hernia repair, I would try to keep the mesh as far away from his ascites as possible and do something like a rectorectus for his incisional hernia if I was able to optimize him well enough.
Perfect, thank you. Anyone else like to weigh in?
So this is Dr. Hassan. I have a question. What does optimizing mean? What do you mean by optimizing it? And how would you measure your degree of optimization?
Yeah, I think I would try to get him on some sort of diuretic plan and have a paracentesis that drains him as much as we can and monitor for recurrence of his ascites. I guess I don't have a great gauge for that, however.
Would the MELD score or have an impact on what you did, or any other objective criteria of liver function? That's for anybody, is actually not to pick on you. You're the only one who was brave enough to ask.
Yeah,
the
no,
question.
it's fine. I mean, I would try to get him to a child's A before an elective surgery if we're able to. But the MELD score doesn't necessarily tell me as much for a specific operation. I would like to see it, single digits if I could, but some of that's out of your control.
I wanted to jump in and just mention, I think this is an interesting case because this patient has end-stage liver disease. So one thing, Dr. Hassan, is that the MELD gets really thrown off because the creatinine is such a key factor in calculating your MELD, that sometimes the child's pew can be a little bit more helpful here, and that's sometimes something to keep in mind. The other thing is, while people think that nephrotic syndrome or renal failure in itself can cause ascites, it really doesn't. It causes anosarca. Ascites itself is usually related to central portal hypertension, and we actually have like one of the lead world's experts on this with Dr. Rosemurgy on the call, who may comment. But Dr. Kircher, I mean, you two, what are your thoughts?
Yeah, I would say that CT scan, that's an immediate showstopper for me, that the degree of ascites. And I'll be interested to hear Dr. Rosemurgy's comments. I may be a little bit more demanding about this maybe than some, but I want these patients as dry as absolutely possible before I do an elective hernia repair. And so the idea of paracentesis, for me, if the patient is requiring regular paracentesis, they're not ready, at least for me. So I'm going to insist that that patient go on dual diuretics and even potentially have a TIPS to mitigate the ascites. Regular paracentesis for me is an indicator that they're not adequately controlled for an elective repair.
Excellent. Brianna, do you want to continue?
Sure. Thank you for everybody's comments. And I believe there, have been studies kind of looking at a MELD score at prognosticating post-op morbidity. And in cirrhotic patients, there have been studies showing that a MELD either greater than 11 to 15 can actually correlate with worse outcomes. So MELD score may be one of many indicators that a patient is medically optimized to undergo repair. So with regards to our operative plan, we did decide to take him to the operating room with plan to perform an open myofascial advancement with or without a component separation, depending on our operative findings and whether we can close the defect reasonably without undue tension. We did discuss with the patient use of a bioabsorbable mesh onlay. And once again, that was in the setting of ascites and keeping the mesh far away from the ascites and reducing kind of the risk of potential subsequent wound infection. So in the operating room, we started off by making an incision in the area of his prior midline incision. We did dissect down to the hernia sac and open up the hernia sacs, at which point it revealed that it only contained ascites fluid. We were able to resect the hernia sac back to healthy fascia, and we identified just really 3 small separate fascial defects that were fairly small in size. So at this point, we did decide to primarily close the fascial defects after performing a limited myofascial release. And then we did an onlay with Phasix absorbable mesh, and we did place a closed suction drain in the subcutaneous space due to potential seroma or hematoma formation. So unfortunately, early on post-op day 1, the patient did become relatively hypotensive to the systolics in the 80s, low 90s. He, on exam, had a visible hematoma under his midline incision. The JB train had limited output because it had clotted off. We did send some repeat labs. His H&H had trended down to 7.5 and 23 from a preoperative H&H of 10.3 and 32. And also because of the need to resume his anticoagulation and antiplatelet pretty soon after the surgery, per recommendation of his cardiologist, we did take him back to the OR for hematoma evacuation and did ligate some small bleeding vessels. And so post-operatively, we did initiate a workup for liver dysfunction. His INR did trend up to a maximum of 4.3 from a baseline of 1.5. As part of his workup, he had a hepatitis panel sent, which was negative. He did have ultrasound performed, which demonstrated a large amount of ascites and an irregular liver capsule, suspicious for cirrhosis. He was started on a diuretic prior to discharge and continued on that on discharge, and then subsequently referred to GI for further workup of his liver dysfunction. So since then, he's had paracentesis performed with fluid analysis sent, and he was started on a low sodium diet. He did see us back in clinic about 2 to 3 weeks after the surgery. There was no evidence of a recurrent bulge or hernia at the time.
What was the pressing indication for taking the patient to the OR? This Alex Rosemary.
So in terms of taking him back to the operating room?
No, taking him to the OR in the first place. In other words, not every hernia needs to be fixed. Not everybody needs to be reoperated upon. I mean, there must have been some reason why you said, oh my gosh, we need to go to the OR. I don't have any idea from your presentation, maybe because I'm not listening so well, I don't know, but about what his medical preparation had been for the operation. There was no pressing need for an operation. Why not medically manage the guy so he gets to be in A1 shape? And then I'm curious as to why you refer the patient to GI.
Yeah, so with the initial operation, he was kind of in consultation with the patient in clinic. He was reporting being more symptomatic from the hernia and increasing in the size of the bulge. He did not have obstructive symptoms. So with that regard, it wasn't necessarily a semi-urgent or an urgent indication for the operation.
Yeah, if this is the patient I recall, sorry, I wasn't able to sign into Zoom until just a few minutes ago, so I missed the initial presentation. But if this is the patient I recall, the ascites was not known. We didn't know this patient had liver failure. And on presentation in the office, this was just a man who looked like an overweight person who had a hernia with bowel involved, because we could easily reduce them and it felt like peristaltic bowel. He didn't have obstructive symptoms, but the worry was that with the at least 1 or 2, I think we had diagnosed the three defects preoperatively on examination. We did not get a pre-op CT in this patient, so if a CT was shown, that was post-op. So this is a patient that if I had known ahead of time he had liver disease, yeah, I would not have electively fixed a hernia or tried to fix a hernia.
Oh, his ascites wasn't that bad pre-op. I think we'd be able to know if somebody had big time ascites, 10, 11, 12 liters of fluid in there, whatever, pick a number, we'd be able to tell it preoperatively.
Yeah, and on
Yeah, it was a
exam,
surprise to us operatively, and that's where the GI referral came from. It was a
It was a native referral for new onset or newly diagnosed liver failure, which actually the initial GI consultation was, I don't think this is liver failure. And then finally, when the labs came back, they were like, oh yeah, this is liver failure.
Was this in an old incision, or was this just a de novo primary defect in his fascia?
It was a old incision. He had a prior open colectomy through a midline incision.
For what?
It was for diverticular disease. We didn't have specific records as it was done fairly remotely. So.
You knew it wasn't cancer.
Sorry, what was that?
You knew it wasn't done for cancer.
Yeah, we knew that it was done for diverticular disease, correct?
So it brings up a good question about whether you routinely pre-op image all hernia patients before taking the operating room. I don't, and obviously if I had, this one would have been caught.
I don't have a, I'm not to mean to speak for the group here, but I don't have a hard and fast rule. As you know, rules are made to be broken. I have some guidelines in my head. And if there's any suspicion or if anything could have been screwed up before it got to me, I'm going to backtrack on those things and study them. I don't want to say that everybody needs an imaging study, but it seems that by the time they get around to us, they've had about $30,000 worth of images obtained that they bring to us and that are worthless.
Yeah, I agree with that. I don't routinely image either.
Yeah, needless to say, operating on a patient with notable ascites, doing an incisional hernia repair, and then it's just, it's going to fail. It's going to fail because he's going to suck up a bunch of volume post-operatively. His ascites is going to get worse. So you either need to fine tune them then, or if you were really pressed to operate on them, there's some things you can do, all of which are a little bit like poking a skunk, but you could have left a drain in place and drained his ascites for 4 or 5 days until his midline wound became watertight. But
Yeah,
I do have a question to ask, just curious. Is there anybody that would have operated upon this patient originally with anything other than a midline incision? I mean, obviously robotics, laparoscopy would have been an option today, but given the time when he was operated upon, would anybody have operated upon this fella through a transverse incision? Other than me?
Alex, how would you do a transverse with a previous midline and 3 separate defects in it?
That's what I said, as an initial operation.
Oh,
I wouldn't do the reoperation through that, but I'd have certainly done his first operation through that.
I think Dr. Rosemurgy is showing his University of Chicago and Michigan preferences, and because that was a classic operation that was touted to have a decreased risk of hernias. But Dr. Benzie, do you want to keep moving with the presentation?
There are some double-blind prospective randomized trials which have been done over the past 20 years comparing paramedian, midline, and transverse incisions, both for early and late wound failure. They're out there for people to read if they choose to read them, but oftentimes you'll hear people say, well, that's the way I was trained. But I don't think that I do anything because that's the way I was trained. And I wouldn't think you would either. Gosh, if we were trained in anything, it was intellectual curiosity.
yeah. So the question about what to do once you discover unexpected ascites, I think is a reasonable and valid one. And my answer to the question of putting a drain in is my experience with that is very bad. And that when I found unexpected ascites, whether for malignancy or for liver failure, when you leave a drain in, it tends to be a drain that can never come out because the output continues to stay high. And when you do take it out, it becomes a fistula. The hole never closes properly.
That's absolutely contrary to my experience. And it's the same for a post-op acidic leak. You dry them out as best you can, and and you go with it. And in this case, placing a drain for, he's going to be in for 4 or 5, maybe 6 days, but more likely 5 than 6. And in that time period, you're getting them on the spironolactone, which, as you know, takes a while to begin to work. It doesn't work with first dose. It takes 4 or 5 days for the spironolactone to kick in, and then the Lasix. And generally, people start thinking, well, I don't want to go on and on, but I've done this many times, and I've also taken care of lots of patients with acidic leaks, and it's basically the same premise.
So, I do want to make sure that we move on. Dr. Kircher, at your institution where you have, transplant and HPB, is there any role for preoperative tips in a patient like this?
Absolutely. When I know about these patients preoperatively, I typically will have the hepatologist involved. In fact, usually they're sent to me by the hepatologist. And it's amazing to me how often the hepatologist sends me a patient for a hernia repair when the ascites is not controlled and they're on one diuretic. And I frequently, despite the fact that I think we have really good hepatologists, have to loop back, and I had to do it this week with a hepatologist to ask them to please help me help the patient by optimizing them preoperatively. And if diuretics aren't adequate, then yes, TIPS is absolutely an option. And we've had pretty good success with that in our patients. And what I found is that in many of these patients, and you all know this, what they don't understand is that the hernia is the proverbial tip of the iceberg. Once their ascites is controlled, these folks with inguinal hernias and umbilical hernias, frequently their symptoms nearly go away. And I think some of this revolves around educating the patients that if we don't get your ascites under control, number one, we're not going to be able to do a safe operation. Number two, your symptoms are going to persist until we can do that operation. And number three, if you force us to do that operation before your ascites is controlled, we're risking all these other postoperative complications of acidic leak and mesh infection that none of us wants to deal with.
Right. And I think also just the point for the trainees on the call is you need to know what you're asking for when you're asking for tips for this circumstance. The pressure drop is different than when you're asking for tips for bleeding. You actually want the pressure drop to be less than 8 for ascites management, which is a higher risk of encephalopathy. But as Dr. Kircher correctly said, this is really something that has to be managed, preoperatively. Dr. Benzie, should we move on with the presentation?
Yes, please, Brianna, if you could just let us know the follow-up for this, and then some of your data that you discuss.
Yeah, I would take the other side of this issue with the tips. I would, first of all, I love to talk about this stuff, but the tips in this patient to me is like the first step of an autopsy. I just can't emphasize it enough that you got to get the patients medically prepared. For the very few patients that can't be medically prepared, then the issue is how long are they going to live? The beauty of a TIPS is it's only got a 50% 1-year patency rate, even with assistance. So 1-year assisted patency rate. And I've been a lot of water under my bridge, and I don't think I've ever put in the TIPS in a circumstance where people haven't bled. I did do a randomized trial of dealing with ascites years ago, comparing TIPS to large volume paracentesis, and large volume paracentesis 1, and others have done that as well. And the large volume paracentesis is better than TIPS for patients. And I don't want to complicate that statement with hernias, but just for patients in general that are in preparation for operations, whatever it be. Boy, you introduce a whole bunch of variables with the TIPS.
Okay, Brianna, can we just move on, please, to your next slide?
Thank you. So this was a study looking at cirrhosis as a marker for adverse postoperative outcomes. So this used a large national database, the University Health Consortium, to look at 32,000 patients undergoing hernia repairs between 1999 and 2004. They compared post-op outcomes between cirrhotic versus non-cirrhotic patients. And as you can see, many factors, including ICU admission, the need for emergent surgery, overall morbidity and mortality were significantly higher in the cirrhotic patients.
Annie, Alex here again. You know I'm a pain in the ass, so I can mention this to you, but emergent surgery, the word emergent comes from emerging, like emerging technologies or emerging nations or whatever. Emergency and emergent are entirely different things. And if you mean emergency surgery, you should put emergency surgery. But remember that surgery is a discipline. It's not a place we take people. It's not something we do. And I don't think, just parenthetically, I don't think surgeries is a word. So when people say the patient's going to undergo surgery, he's going to undergo an operation, procedure, whatever. But emergent doesn't belong, and surgery is a discipline. It's not a thing we do or a place we take people.
Alex is absolutely right, but actually the term surgery refers to an office where old-time English physicians used to see patients.
Well, that may be before me.
So just out of respect for our presenter, I really want to let her finish with her data. Dr. Leong has put a lot of work into this.
Then they shouldn't raise so many issues in their presentations.
Understood. Thanks, Alex.
That was meant to be lighthearted.
Thank you, Dr. Rosemergy. Looking at outcomes in patients who underwent an elective hernia repair versus non-operative observation. So this was a prospective cohort study that was published in January 2020, studying patients between 2009 and 2014. This study, in this study, patients were given the option to select their treatment, either elective hernia repair or non-operative observation. The advantages and risks of each option were extensively discussed before reaching a decision. And 57 patients, they chose to undergo elective repair versus 189 who chose to undergo the wait and see approach. For all elective repairs, all umbilical and incisional hernias were repaired primarily with onlay polypropylene mesh and a subcutaneous closed suction drain placement. And inguinal hernia repairs were done with an open Liechtenstein technique. Unfortunately, about 23% of the patients in the non-operative group subsequently did go on to require emergency repair, either secondary to development of bowel strangulation or incarceration, or umbilical rupture and ascites leakage.
Hey, Annie, out of curiosity, what do they mean by conservative treatment?
Non-operative treatment. I think of you every time I hear that.
I know you do. So what's the conservative management of a ruptured spleen?
Taken to the operating room.
That's right. So the word, the confusion of conservative and non-operative being similar or meaning the same thing is totally erroneous. I appreciate you're taking this from a study. I'm not beating on you. I'm just making the point that conservative treatment is a huge misnomer. Bad term.
Okay, Brianna, keep going.
All right. So this is from the same study. So here on the left graph, basically showing that patients who elected non-operative management had a significantly decreased 5-year survival rate compared to those who had an elective repair performed. And then on the right, the elective hernia repair group had a higher 30-day survival compared to the emergency repair group. Independent risk factors that they found for higher 30-day mortality was a MELD score greater than 11 and the need for emergency hernia repair. In terms of assessing the severity of liver disease, in your preoperative evaluation, you want to assess for liver dysfunction. The MELD score is the best way to identify the severity of liver disease and prognosticate post-op morbidity and mortality in cirrhotic patients. So this table shows the expected 3-month mortality rate for cirrhotic patients by MELD score. So worst outcomes for abdominal surgery have been reported for a MELD score greater than 20. And with regards to elective hernia repair, you should optimize the sequelae of their hepatic dysfunction as much as possible. So as we previously talked about, cirrhotic patients are going to have poor nutrition and low protein levels. So you do want to address that. If there is an offending agent or specific etiology for their liver dysfunction, such as drinking alcohol or viral hepatitis, stop the offending agent. You may want to consider placing them on antiviral therapy to decrease their viral loads prior to operating. You want to also correct their coagulopathies as well as their anemia as well. So in order to minimize postoperative complications and really reduce the risk of recurrence after a hernia repair in cirrhotic patients, you do want to control their ascites. So first-line therapies are going to include low sodium diet or salt restriction, usually about less than 2 grams per day. There is also fluid restriction, but this should only be done in patients with evidence of hypervolemia. With regards to their protein levels, if they're in the hospital, you can give them IV albumin, but in the outpatient setting, you do want to orally supplement them with protein, aiming at about 80 to 90 grams of protein per day. We did speak a little bit about diuretics. So spironolactone is the first-line monotherapy. However, in those with recurrent severe ascites and if faster diuresis is needed, you can consider adding on an additional diuretic, such as a loop diuretic. And there's also large volume paracentesis to address the ascites. And for patients whose ascites are refractory to medical management, second-line therapies include TIPS or transjugular portosystemic shunting, which is a stent placed between the portal vein and lower pressure hepatic veins. So several multi-center randomized controlled trials have demonstrated TIPS to be successful at controlling ascites in 80 to 90% of patients who are refractory to medical management. And it's actually been shown in terms of survival to be superior to large volume paracentesis. After TIPS, a third-line therapy, peritoneovenous shunting or the Denver shunt, where your proximal end of the shunt is going to be located in the peritoneal cavity and the distal end in the SVC. And the shunt is basically internalized and takes a subcutaneous course in the anterior chest wall. The advantages of a PVS is that it's a simple procedure. There's really no external component to the shunt, so it doesn't necessarily limit quality of life. And compared to paracentesis and indwelling tunneled catheters, you don't have as much loss of fluid or nutrients. Indications for a PVS is medical refractory ascites, meaning that they've undergone 4 weeks of maximal diuretic therapy and sodium restriction, or they're actually requiring large volume paracentesis every 7 to 10 days to control the ascites. So the most common complication of PVS is shunt occlusion, with only about 20% of shunts remaining patent after 2 years. And then there are surgical portosystemic shunts, but those are probably not used as often. And they're associated with a mortality rate of about 10%, but they can also affect future liver transplantation. Discussion about portal hypertension. So studies have shown that surgical risk of umbilical hernia repair in patients with evidence of portal hypertension, such as esophageal varices or the presence of ascites, the surgical risk is significantly higher. So preoperative assessment for portal hypertension should be done when you're planning for an elective repair. So one of the better indicators for portal hypertension is platelet count. Thrombocytopenia is present in about 60% of cirrhotic patients, mainly thought to be caused by splenic sequestration induced by splenomegaly. So patients should also be screened for varices with an endoscopy within 1 year of surgery. And if they are at high risk for a variceal bleed, such as they have high-grade esophageal varices or they have portal hypertensive gastropathy, then they should be started on prophylaxis against bleeding, such as a non-selective beta blocker. And then some later line therapies for portal hypertension are TIPS and variceal embolization. So before I present some data on mesh, going back to our case, just to kind of quickly pull the audience, would you use mesh in this patient, and also what location would you consider placing it in?
Could I make the argument for not using mesh at all and just doing a primary repair? That's probably what I would have done if there were small defects, right or wrong, but I would avoid a mesh in this situation.
I agree with you, Dr. Hassan. Dr. Kirsty, you're sort of the expert. What do you think?
Yeah, so in a patient that does not have an acidic leak, open wound, incarcerated bowel that requires resection, so an elective, clean case, I would use a synthetic mesh in that patient. And then I think the real question, and this was asked in the chat, and what about an ETAP or some other type of procedure in terms of where you place the mesh? We typically use the preperitoneal space to place mesh. I would say 90% of the cases I do open ventral hernias, I'm going to do a preperitoneal mesh placement. I think that the comment, I think Eugene Cho commented that he wouldn't want to do excessive dissection in a patient that has portal hypertension and varices, and I think it really would depend on the situation. You can get a pretty good assessment as to what that preperitoneal space is like, and obviously if it's full of varices, no, I wouldn't use that space. But in many of these patients that have had chronic ascites, what I find is that the peritoneum ends up being relatively thick, so it's actually a pretty easy dissection to get into that peritoneal space. And I think that does a couple of things. One, it keeps the mesh outside of the abdominal cavity proper. So if the patient develops SBP, your mesh is not going to be exposed. I think that by closing the peritoneum, using mesh underlay, and then getting the fascia closed, you're probably going to decrease the risk of acidic leak. And ultimately, if the ascites remains well controlled postoperatively, you should have a pretty low rate of hernia recurrence.
Dr. Karcher, if I may ask, how would you do this laparoscopically or robotically when you put in the preperitoneal space, and what kind of mesh would you use, and how would you secure it?
Yeah, so for laparoscopy, I do a laparoscopic IPOM, intraperitoneal onlay mesh. I don't use the preperitoneal space laparoscopically. The preperitoneal repairs are typically reserved for open cases. I do my umbilical hernias with preperitoneal mesh, and then certainly inguinal would be a laparoscopic transabdominal preperitoneal repair, at least in my hands. I've got some partners that'll do robotic preperitoneal repairs, but that's not something that I'm doing.
Thank you, Dr. Kircher. So in terms of using mesh in cirrhotic patients, there is a concern for impaired mesh ingrowth and wound infection in the presence of ascites. And certainly in non-cirrhotics, fully resorbable biological mesh or solely resorbable biosynthetic mesh, such as phasics, in complicated hernias has been associated with minimal wound-related morbidity. So this was actually a study, a randomized controlled trial from 2010, looking at the use of polypropylene mesh to treat complicated umbilical hernias in cirrhotic patients with a CTP A or B severity of liver cirrhosis. And they randomized patients to either a sublay polypropylene mesh versus a primary repair. This actually showed that with the permanent mesh, the SSI rate was higher in the mesh group. However, none of these required a mesh explantation or was complicated by exposed mesh or fistula formation. However, kind of echoing the data on use of synthetic mesh in non-cirrhotic patients, the recurrence rate was significantly lower in the mesh group. So we touched upon mesh location. There are different locations to place mesh. There's onlay, where the mesh is sutured onto the fascia after dissection of subcutaneous flaps and primary closure of the fascial defect. Wound complications in this location tend to be more frequent, such as seroma, hematoma, ascites, drainage, because of the extensive detachment of the subcutaneous tissue from the fascia. Which typically creates a dead space. And then the inlay technique, where the mesh is just sutured to the fascial edges, is generally not used very often because of the high recurrence rate. And then there's a sublay technique, where the mesh is placed in the retrorectus location, or underlay, or IPOM, as we had talked about, where the mesh is placed intraperitoneally and fixed to the abdominal wall. Wound complications tend to be less common than sublay and underlay techniques because the mesh is laying pretty deep in the subcu space. But the best location for mesh placement in terms of cirrhotics is still pretty controversial, kind of with low numbers in the studies that are available. And here is just some pictures demonstrating a retrorectus technique. Here they've actually amputated the neck of the hernia sac and reduced the context back into the abdomen. They did develop a retrorectus space here and close the posterior sheath, and they placed a mesh under the rectus and closed the anterior sheath after that. And then just kind of skipping past this, I'll go over some data regarding concomitant drain placement for control of ascites after hernia repair, either with peritoneal dialysis or closed suction drainage. So the first study looked at 8 patients with significant ascites who underwent elective hernia repair, and then they had a peritoneal dialysis catheter placed at the time of the operation. So these patients were followed for 8 to 30 months. All patients had a successful repair of their hernia with 1 recurrence at 6 months. And patients reported being able to effectively control their ascites at home with the use of the PD catheter. There were no postoperative infections. The second study here was a retrospective study of 68 patients undergoing emergent umbilical hernia repair. There was no difference in complications between those who had drains placed and those who had repeated paracentesis for control of their ascites. But the bottom line here is that there were increased complications if there were no measures used to control the ascites postoperatively. And then lastly, this was a retrospective review of 21 patients with advanced cirrhosis and refractory ascites who underwent umbilical hernia repair at a single institution from 2002 to 2008. And 7 of these patients had drains placed, whereas the remainder did not. And this actually demonstrated that there was no significant difference in terms of wound complications between those who had closed suction drains placed versus those that didn't. And just going over some studies comparing laparoscopic versus open hernia repair in patients with chronic liver disease. So this 2017 study looked at patients with a MELD score greater than or equal to 9 who underwent elective hernia repair in the NSQIP database. So 30-day outcomes were compared between lap ventral and open ventral hernia repair, with primary outcomes being mortality and secondary outcomes being wound-related complications, systemic complications, and length of stay. So the laparoscopic group has significantly fewer wound complications and length of stay, whereas mortality and systemic complications were similar. However, when they did a subgroup analysis of patients with ascites, it did show that they had a higher mortality rate and a significantly higher systemic rate of systemic complications, mainly sepsis and renal failure. So this is just echoing previous data showing that patients with signs of portal hypertension, such as ascites, have poor outcomes. And then this 2018 study was primarily focused on inguinal hernia repairs, also looking at the NSQIP database. The mean MELD score of these patients was 9 in the open group and 8 in the lap group. So the lap group had slightly less severity of liver disease, but when they did propensity score matching, it did show that overall complications like the stay and mortality were similar between the lap and the open approaches. So touching upon laparoscopic inguinal hernia repairs in cirrhosis. There is laparoscopic tap repair, but the disadvantage of this is that you do have to close the peritoneal layer, and that entire suture line is at risk for ascites leakage. This study was a small observational study, but he essentially concluded that an elective lap TEP was a safe and feasible approach in terms of, and experienced hands, in that there was no recurrence or chronic pain in follow-up after 10 to 28 months. Among the 17 patients, they did have patients with various degrees of cirrhosis severity. But with the lap TEP approach, you are kind of dissecting in the space where your varices would be running. So there is a higher risk of hematoma formation, and obviously the outcomes are better in experienced hands. So in conclusion, so we have pretty strong data that outcomes are significantly better with elective repair compared to urgent repair. And optimization is crucial prior to performing an elective repair, especially with ascites. Optimal control of ascites is important for preventing post-op recurrence, ascites leak leading to reoperation. And kind of looking at the literature, the role of minimally invasive surgery as far as emergent indications isn't very well defined. And I welcome any questions or comments.
All right, I want great presentation. Thank you for stimulating some great discussion. So I want to draw your attention to these comments. And I think Rohan and Eugene were serious when they said nobody would do is that a TAP or a TEP? So you wouldn't do a laparoscopic or inguinal at all in a cirrhotic? Is that what you guys are saying?
For me, it was TEP, just because that space is so bloody.
I would say, well, I'm just curious. So I think for a patient that has a unilateral inguinal hernia, that's a cirrhotic, Number one, I want their ascites controlled, all the things we've talked about. I would typically do that patient open. I don't think that cirrhosis is an absolute contraindication to a laparoscopic inguinal hernia repair. So if I've got a patient that has bilateral inguinal hernias, as Alex said earlier, most of these folks have some form of imaging. And I think imaging can be really helpful because I want to look for periumbilical varices. I want to know if they have ascites. I may get a sense of whether or not there may be some lower abdominal varices. And that's going to direct me in terms of whether I think that's safe. But I personally would not say that cirrhosis is an absolute contraindication to a lap inguinal hernia repair. Eugene, do you disagree?
Yeah, for me, it has to do with what do you have to gain. So again, if you're talking about bilateral inguinal hernias plus a ventral, you might be able to close as your access site near the umbilicus. Maybe that's a different story, but a unilateral, even in expert hands such as yours, there's not a clear advantage to laparoscopic versus open, other than maybe there's an argument that in a female, you might miss femoral hernias more often if you do it open. But otherwise, because there's not a night and day difference in recurrence rates, I would try to simplify that as much as possible. In that situation, an inguinal in a man, for instance, in a woman, you can close off the whole canal, right? But in a man, you have to leave some degree of flow for the testicle. So it's going to be a bridge repair by definition with a mesh across that. So you're going to expect if someone has a large amount of ascites and it's in their scrotum, it's going to still be there after the repair. All you're trying to do with the repair is stop bowel from getting stuck in there and precipitating a necrosis or emergency. But you're not going to fix their swollen scrotum because fluid is going to go through whatever opening you leave for the testicle to get air for the new internal ring. You're going to get fluid in there. That reflects back to Brianna brought up the question of mesh, and if you had to bridge a defect with a cirrhotic patient, say a large umbilical, and you can't get that together. To me, that's the one indication in this day and age for still using a impermeable waterproof mesh like Gore-Tex, where even though there's an incidence or some people's bodies will attack that and shrink that down drastically over time, to me, I want that repair, that mesh to be not something that's permeable easily by fluid. Otherwise, your skin's going to stretch the heck out of it. And the same problem that arises when you have chronic incarcerated hernias, even in non-cirrhotic patients, where that skin is chronically ischemic. To me, that's a reason to do that open, because you have to excise that tissue or expect it's gonna necrose, and then your polypropylene is sitting there exposed to the air.
You also don't have to excise the hernia sac. You can just invert it or just purse string it. But by not opening it, you don't then leave a point of egress for the ascites.
Yeah, that's a great point. And there's actually a school of thought coming out of the TEP fans, the ventral hernia fans of the TEP, of preserving that sac just to close that bottom layer underneath the mesh and using it as a bolster and essentially as an anti-adhesion barrier. So that's something that's come full circle from back when I was a resident. It was the teaching was to excise the hernia sac entirely. I will say in this particular case that Brianna presented, again, this was a surprise finding of ascites. And so we'd already gone through the process of dissecting out 3 hernia sacs intact, which for all the world looked like squishy bowel that was stuck in those sacs. It was only when we tried to reduce the level of the fascia to actually get the closure, we'd already dissected out the sacs entirely, that we discovered, oh, that's not bowel, that is actually fluid under pressure from inside. And so once we'd already gotten that point, even though there were 3 small defects there, we chose to close those primarily because obviously I don't want to have a bridge mesh with fluid leaking through it, but also because at 1 centimeter, even though you're correct, Alex, that the risk for recurrence is extremely high if the ascites isn't controlled. We'd already dissected out that space in the preperitoneal, or sorry, in the subcutaneous space in order to get those sacs dissected, and that's why laying a absorbable mesh into that space that was already dissected essentially was for me a better choice than making a new dissection in the preperitoneal plane.
Dr. Ketcher, we have just a minute, but I wanted to ask your thoughts on terminology. You know, we're really moving away from using the term hernia, right? And we're really talking about ab wall reconstruction or abdominal core health. What are your thoughts? I know you all have been leaders in this sort of area of the American Hernia Society, despite all of the terminology.
I still use the term hernia. I think that it is interesting that when we interview residents and fellows, Many will say they want to specialize in AWR or abdominal wall reconstruction. And so I think we should probably take some pride in the fact that it really has become an area of subspecialization and expertise. So I think that maybe using that term gives us a little more credibility. But I would say certainly when we're talking to patients, the word hernia certainly works pretty well for me.
And do you want
Excellent.
to take us home?
Yes, thank you, Dr. Jayaraja. So thank you very much, Brianna. Thank you, Dr. Kutcher, again for being our moderator, and thank you for everyone for this very lovely and thought-provoking discussion. Our next session will be on December 12th. The topic is the surgical management of gastroparesis. So please check your email boxes for the invitations to those. And again, thank you all so much and have a great night.